Again, here's the agenda. I'll be talking first about IO in advanced disease. Then we'll hear from Dr. White about intermediate disease, which is perfect for an interventional radiologist because of the importance of local regional treatments in that setting. And then Dr. Yarshwin will talk about the neoadjuvant and high-risk potentially curative setting. And Dr. Yarshwin's done a lot of excellent immunology and science in this setting. So our objectives tonight are really to understand the biologic and clinical rationale for targeting the immune system with checkpoint inhibitors, VEGF, TKIs, as well as IO combinations, how data should be influencing your practice in not only advanced, but now potentially resected and intermediate disease, and then apply this evidence to help you guide treatment decisions for your patients, and also be aware of ongoing data. So I'll get started with my section here, and we're going to start with a case. This is someone I've followed for some time now. 62-year-old gentleman, had weight loss and right upper quadrant pain, presents to his PCP. He has a history of type 2 diabetes, cured hepatitis C many years ago, and hypertension, and on exam he has a palpable liver mass. He gets a CT scan with contrast, which shows a cirrhotic liver with an enlarged spleen, has an 8-centimeter right lobe lesion that enhances on the arterial phase with venous washout, with tumor thrombus in the right portal vein extending to the main portal vein, also known as VP4. These are his labs. Notably, he has a platelet count of 87,000, bilirubin slightly elevated at 1.6, albumin towards the lower end of normal at 3.4, AFP is 1600, liver enzymes are mildly elevated, and he has a normal INR. So this is our question. What would be the next step in planning evidence-based and guideline-driven immunotherapy combination, i.e. with atezo-bev, as first-line treatment for this patient? What would you do next? A tumor biopsy, B, an upper endoscopy, obtain an MRI, or start lenvatinib. It looks like the audience is largely split between a tumor biopsy and upper endoscopy. A few said MRI, and then some said start lenvatinib. So, technically a tumor biopsy is not necessary for this patient because they meet non-invasive criteria for the diagnosis of liver cancer. He's cirrhotic. He has a hypervascular lesion that washes out on the venous phase. And in the context of hepatitis C, this is diagnostic for liver cancer and actually the inclusion for most clinical trials. Biopsy is not required. There is a movement in the field to move to doing biopsies, partly for academic reasons. There is some incidence that, it's not only pathology is 100%, but this is well over 90-95% likely to diagnose liver cancer. Start lenvatinib is not necessarily a wrong answer. Right? Lenvatinib is approved in the front line. It was shown to be non-inferior to sorafenib. The question is, why start lenvatinib front line when there are regimens that have been shown to be superior to lenvatinib? And we'll talk about those, right? Atezo-bev, durvalumab, and tremelimumab. There'll be data on Tuesday from a new phase 3 study with ipilimumab and nivolumab that has superiority. So again, starting lenvatinib is not wrong, but I think we would ask ourselves, why can't this patient get an IO regimen? Now, upper endoscopy personally would be my choice here. And the reason for that is if we were moving this patient towards starting atezolizumab and bevacizumab, a frontline option, this patient has thrombocytopenia. All patients included in the IMbrave study 150 had upper endoscopies to rule out the risk of bleeding varices. So when we approach liver cancer patients, by and large, the default staging system has been the BCLC. And, not to go through this in great detail, because right now we're focusing on those patients who are candidates for systemic treatment. And who are those patients? Advanced stage C patients are those that have extrahepatic spread, so metastases, or macrovascular invasion. That means you do a scan and you see the tumors invading into the vasculature of the liver. However, increasingly, we're becoming aware that there's probably patients who technically might be intermediate, i.e. liver-confined disease, good performance status, compensated liver function, who might be better served with systemic treatment rather than local regional treatment. And while that criteria is kind of, I know it when I see it, often it's patients who have large, diffuse, infiltrative tumors that we would speak to interventional radiology, and why it might be, yes, I can embolize that, the outcome is not expected to be excellent. And in that case, increasingly, more patients are getting medical treatment up front. And if you look at all the phase 3 studies that are being done, about 20% of them are these intermediate patients, otherwise known as Barcelona B. The other group that will be getting systemic treatment are those that are intermediate and progress, right? I've often said, if someone has intermediate liver cancer and they don't get a liver transplant or some curative approach, or they don't die of some other comorbidity, eventually those patients will progress and become advanced, i.e., they'll develop extrahepatic spread, they'll develop invasion into the liver, or despite repeat local regional treatments, they'll have residual disease. Okay. So, the data as it stands today recognizes really 4 regimens that have been shown on level 1 evidence to improve survival. Initially sorafenib, and then after 10 years we got lenvatinib based on non-inferiority on the REFLECT study, though it did have superiority for progression-free survival and objective response rate. And then came atezo-bev, which was superior to sorafenib based on OS, PFS, and ORR. And then more recently, we saw the approval of the IO-IO regimen of durvalumab and tremelimumab, which again showed an improvement in overall survival and objective response rate. And then in second line, nothing technically is approved after frontline IO. All the drugs we have been approved in the era before IO. So in practice, we do sequence these drugs. How best to sequence them is really expert opinion. And from a regulatory standpoint, we don't have something that is specifically labeled, if you get atezo-bev or durva-tremi up front, this is the drug you need to get. Many of us do sequence frontline TKIs, such as lenvatinib or sorafenib, which are now second line, and then cabo or ramucirumab or regorafenib, and that just shows that in more detail. So let's run through the phase 3 studies. IMbrave 150 was the first of the modern age studies to read out. I was very fortunate and blessed to be part of this study, and it was a global study of atezo-bev versus sorafenib in the frontline setting, randomized 2-to-1. The primary endpoints were overall survival and progression-free survival. This was an open-label study because it was IV versus oral. And importantly, because of concerns with bleeding with bevacizumab, all patients had to have an EGD within the past 6 months. And even if they had varices, they could come on study as long as they were managed per the local site. And these are the results. This study was stopped at its first interim analysis because it met its overall survival endpoint and PFS endpoint. With longer follow-up, we see the median survival in this population was over 19 months, with a hazard ratio of 0.65 for PFS, so like a 35% decrease in the risk of progression. And importantly, objective response rates were 30%. That includes 8% complete responses. What we don't have here is a biomarker to tell us who's going to be the responder. But if you respond, these are very durable responses. And when we look at treatment-related adverse events, 43% versus 46%, very similar between both arms. Discontinuation rates for one drug in atezo-bev was like 15% versus 10% with sorafenib, but to completely stop the regimen, it was only 7%. So some patients might have stopped the bev if they had hypertension or proteinuria, but could continue on atezolizumab. And this study shows that if you had a response, your survival was very good. You can see at this analysis, the median OS for responders still had not been reached out over 20 months. These other graphs are landmark analyses, which are often done when we're looking at this. Even patients who had stable disease in yellow, their median survival was quite long, 17 months. And I would argue an unmet need for us in the liver cancer space are patients who don't benefit from frontline IO. If your best response is progressive disease, your prognosis is very bad, right? Here in this study, his median survival was 7 months. The other thing to keep in mind in IMbrave 150 is we enrolled patients who have main portal vein invasion, VP4. Some studies have excluded those patients because they're very high risk. And even though they were high risk, they still got a benefit to atezo-bev. But even with atezo-bev, their prognosis is not great. It was like 7 months versus 4 months, 4 or 5 months with sorafenib. So it was improved. But I would say we have two still unmet needs in patients with advanced liver cancer, those who don't respond to frontline IO and those who have main portal vein invasion, which hopefully we can do better. Here you see the treatment-related adverse events. Certainly, most of the AEs we see with atezo-bev come from the bevacizumab component, hypertension, proteinuria. You can see that things a patient would notice more, such as GI toxicity, diarrhea, hand-foot skin reaction, these are happening much more frequently with sorafenib. And therefore, when we look at quality of life data, we see that it markedly favors atezo-bev. The other thing I would mention here is, of course, we see immune-related adverse events, as we see with any IO checkpoint inhibitor. But atezo-bev is very similar to the toxicities we see with single-agent IO, with only about 10% or less patients requiring steroids for immune-related adverse event. Now, I want to focus on bleeding very quickly because that concerns a lot of people, as it should. It can be a serious event. If you look at all-grade bleeding events, 25% versus 17% with sorafenib. But if we look at grade 3-4 events, higher grade events, fairly similar, 6.4% versus 5.8%. And most of the adverse events tend to be low grade, epistaxis, hematuria, gingival bleeding, etc. When we look at significant adverse events, concentrating on those here that occur at more than 2%, you can see that if we're looking at grade 3-4, and remember the study was randomized 2-to-1, but we see about 3% of patients with atezo-bev having grade 3-4 GI bleeding events versus 2.5% with sorafenib. Now, there were 4 grade 5, that is a death event with atezo-bev, and none with sorafenib. But we've identified that those patients who have these grade 5 events typically have VP4 invasion or main portal vein invasion. And the other thing that I think is important to keep in mind is when does this bleeding occur, right? Keep in mind, bevacizumab is not heparin. It's not an anticoagulant, though it has a biologic effect that puts patients at risk for bleeding. But you can see here all grade bleeding events with or without varices occurred at a median time of about 7 months. And if we look at just those patients like grade 3 or higher, with or without varices, again, they occur in several months. And here you see the patient-reported outcome data favoring atezo-bev. So let's talk about the other frontline regimen that has phase 3 positive data, globally approved, and that's durvalumab and tremelimumab. Tremelimumab is the first drug of its kind in the liver cancer space. It is a CTLA-4 antibody. You'll remember that CTLA-4 is involved in the immune priming phase of the immune system, whereas durvalumab, atezolizumab, nivolumab, pembrolizumab work on the PD-1, PD-L1 axis. And this study's primary endpoint was to compare a single high dose of tremelimumab added to durvalumab versus sorafenib. There was also a single-agent durvalumab arm here that was powered for non-inferiority. And again, a well-powered study. This study did not involve patients who had main portal vein thrombosis. Here you see the primary endpoint. Again, a positive study with a hazard ratio of 0.78, so that's a 22% decrease in the risk of death with the addition of tremelimumab to durvalumab versus sorafenib. Durvalumab alone did meet its non-inferiority endpoint with a hazard ratio of 0.86, and the upper limit of the confidence interval of 1.03 was less than 1.08, the boundary to declare non-inferiority. Needless to say, the current FDA approval is with durvalumab and tremelimumab based on its superiority to sorafenib. There was no difference in PFS. I should comment the objective response rates with this regimen actually were about 20%, higher than we saw with sorafenib, and very provocative. I mean, this is really the first of its kind data that was presented only in the past year. Himalaya has long-term follow-up for their patients. The study went to its final analysis. And we can now see that patients with advanced liver cancer who got started on the STRIDE regimen, 25% 4-year survival versus 15% with sorafenib. Here you see even with single-agent durvalumab, that was about 19%. And here is the objective response rate data I was referring to, CR and PR rate of 20%. And again, if you have a response, your 4-year survival here is 67%. If you have a CR or PR, patients with stable disease, 4-year is 25%. So again, one of our main objectives now in the liver cancer space is to get an objective response. And I think in the future, as we develop new drugs and new combinations, the goal will really be not only to improve survival, but to get a response. And that is why I think when we see patients progress on frontline IO, their prognosis isn't great because we don't see long, durable responses necessarily in second and third and fourth line. But needless to say, you see here patients with STRIDE who have disease control, which would be stable disease and an objective response. The 4-year likelihood of survival, 36%. That means 1 out of 3 patients who have disease control are still alive at 4 years. I may look young, but I've been in this space for a long time, and it's incredible to see how long patients are living with liver cancer. And we're getting more patients who are better compensated, and to be honest, some of them are outliving their liver disease, right? We have patients who would have died of liver cancer 5-6 years ago. But because their tumors are controlled, they're starting to develop more symptoms of portal hypertension and end-stage liver disease. And they're not necessarily dying of tumor burden. This regimen is a purely IO regimen, so the side effects are related to immune-related adverse events by and large. And what's really, I think, very interesting biologically is that we see even a single dose of tremelimumab doubles the treatment-related adverse events. And you can see here with this regimen, 20% of patients needed high-dose steroids as compared to those patients who needed steroids with single-agent IO. And like we saw with atezo-bev, you can see that favoring in quality of life with durvalumab and tremelimumab. And again, that relates to the fact that while we do see immune-related adverse events, taking daily oral sorafenib or TKIs has a different side effect profile. There's been regimens of TKIs and immune checkpoint inhibitors, kind of mixed results. Cosmic 312 looked at cabo and atezo, and while it met its PFS endpoint, it did not improve overall survival, and there was no effort to get regulatory approval. LEAP 002 was presented not long ago, recently published. We did not meet our overall survival endpoint, or PFS. What was quite striking, though, is while len-pembro did have a survival of 21 months, lenvatinib alone had a survival of 19 months. And you remember in the REFLECT study, survival was 15 months or so. So the natural history of liver cancer has changed. And what's remarkable, I think, is len performed very well here, just like it did as far as objective response rate. In the pivotal study, an objective response rate of 18-19%. And now we see a 19-month survival. But keep in mind, this 19-month is not the same 19 months we saw in IMbrave 150, because these patients did not have main portal vein invasion, right? The natural history of that group of patients is different. So CheckMate 040 led to the accelerated approval of nivolumab and ipilimumab. This was a second-line study after sorafenib. 3 different dosing regimens that all gave a very similar objective response rate of 30%. This dose of Nivo1 IPI3 had a survival of 23 months compared to a year for the others and was selected to get accelerated approval. Again, if you respond, you do very well, long duration of response. However, about 50% of these patients in this study needed steroids for an immune-related adverse event, which was mostly transaminitis. But again, here you see if you responded, that's great. And again, if you have PD, and this is in the second-line setting, your prognosis is very different. And here you see the adverse events. Again, grade 3-4, you can see pruritus, rash, diarrhea, AST elevation, driving a lot of the steroid use, as well as ALT. But I will call your attention to this presentation happening on Tuesday. It has not been released, but we know this is a positive study where patients get nivolumab and ipilimumab for 4 doses every 3 weeks, and then maintenance nivolumab versus sorafenib or lenvatinib in the frontline setting met its primary endpoint of OS. So we're all very excited to see this data set. Also positive when we talk about TKI and immune checkpoint inhibitors was the CARES 310 study. Look at pembrolizumab and rivasirnib versus sorafenib. Neither of these drugs are currently approved in the U.S. Rivasirnib, also known as apatinib, is approved in China. It's a very potent VEGF TKI. And this study looked at this regimen versus sorafenib. PFS and OS were the primary endpoints. The majority of these patients, 83%, came from Asia, and as expected, most of them had hepatitis B. This study was very positive. Again, very similar to IMbrave 150, hazard ratio 0.62, 22-month median survival in this high-risk population, objective response rate 25%. A fairly high toxicity profile here, 80% grade 3-4 toxicities with this regimen, even though it improved survival, improved PFS. We heard from the FDA that this regimen will not get approved in the United States, not because of any questions with the data per se, but apparently there's been some manufacturing concerns with pembrolizumab, so we'll have to wait and see if this hurdle can be overcome. But clearly an active regimen. So we have IO-TKI, IO-IO, and IO-VEGF regimens that have all been shown to be active in frontline liver cancer. And one of the challenges is, which is the right regimen for the patient sitting in front of me? So here's a question, I think a follow-up question. What would be the next step in planning evidence-based guideline-driven therapy combination treatment for the first-line patient we talked about? So here, it looks like I convinced some of you, not all of you, but it's okay, it's fair. There's no right answer. Everybody gets an A. And we talked about my rationale for doing an upper endoscopy. And even if you're not going to do atezo-bev, to be honest, if a patient presents with liver cancer and is cirrhotic, and just because they haven't been followed closely has never had an endoscopy, it's probably worth doing. That's just good internal medicine for these patients, regardless of what regimen you take. So, before we go to Dr. White, I want to comment about some of the other abstracts that are coming up here at ASCO. I commented on the Checkmate 9DW session. There's also going to be an interesting presentation from my colleague, Anthony El-Kohiri, looking at regorafenib and pembrolizumab, right? So this is a different TKI IO regimen. And then there's many posters updating data on durvalumab, as well as this one here with atezo-bev, looking at patients that we might see in practice, not in clinical trials, such as those with less compensated liver disease. And before we go to Dr. White, maybe I'll ask my colleagues. Mark, when you see the patient I presented, right, what's your thought process in choosing a regimen?
I think it's tough, right? These regimens have never been compared head-to-head, and we have multiple positive studies. So, I don't think there's one correct right answer. I think a little bit of it has to do with the tempo of the disease. Of the 2 approved regimens, if you really need a response, again, there are all sorts of risks of cross-trial comparisons, but I think if you really need a response and pending liver failure, I'd go with atezo-bev just because of the higher response rate. I think a patient with a small amount of disease who has time for a response, I think durvalumab is a very appropriate answer as well. So I don't think there's one right answer.
I see my good friend Dr. Kudo in the audience, and I'll ask you, Dr. White. I mean, some patients are getting IO for advanced disease, and they have a great response, a lot of them. Mm-hmm. And something I wrestle with, I have patients on IO regimens now 18 months, right? And maybe they had a large tumor in the liver that was beyond criteria. Maybe they had vascular invasion, small extrahepatic met. They've had a great response. Are these patients coming to you in interventional radiology to consolidate? Dr. Kudo has talked about conversion therapy, taking something that was incurable to maybe curable. Because otherwise, you're looking at IO until progression, right? And that could be years if it ever happens. What are you doing in radiology?
I think if we have stable disease, we don't tend to do consolidative therapy for HCC, but if we see progression at that point, or if we have oligoprogression, so most of the disease is in check, and then we have one site, then we'll go after that. But if they have stable disease, we are not, at this point, I don't think any of us would do consolidative.
I mean, I've started to be honest. I mean, only in the past few months, because
right.
I don't know what's going to happen, right? I mean, It's not completely flat, that curve. Mark, what are your thoughts?
Yeah, I think our practices are all over the place, and we're figuring it out, but I've started to consolidate.
Yeah, I mean, and this leads into an adjuvant study, maybe TASTE or Y90, then give a few months of additional IO. I think we're all waiting for more data in that area. And toxicity. I mean, are you seeing patients every 3 weeks or every 4 weeks whenever they come in for their infusions, or do you see them in between, Mark? How do you manage the follow-up for your patients?
Yeah, I mean, I think most of my patients are seen every cycle. We've participated in Nivo-IPI studies, which may become an option. And, I think the rate of IREs is clearly higher with that regimen, and many of the fatal IREs happen within the very early time point. So I actually like to see those patients a little more often. So I'll actually see them at 2 weeks and 4 weeks. So in between cycles, just for the first couple of, especially if I practice in a place where a lot of my patients don't necessarily call me, so we monitor them a little more closely.
Yeah, right. I mean, the patient who comes in and hasn't been feeling well for a while, and why didn't you call, right? The last question before we go to Dr. White is, all the clinical studies are done in patients with Child-Pugh A, right? Clearly, most patients in our practice are not clinical trial candidates, right? So, I know when I see a patient, certainly their liver function is important, right? But just because someone isn't Child-Pugh A does not mean I won't offer them treatment, right? And I think an important teaching point, some patients have decompensated liver disease or abnormal labs because they have a very high tumor burden, right? And these patients, if they respond, they get better. And that's different from the patient who's cirrhotic, has ascites, encephalopathy, and then develops liver cancer, right? That patient, maybe their prognosis from their cancer is not as significant as from their liver disease. But, I know of patients who, if someone is just too orthodox about the use of Child-Pugh, there are patients who are not being treated who likely could benefit from treatment. I mean, Mark, do you have any comments?
No, I totally agree. I mean, I think it's important to know that the Child-Pugh score was never designed to assess HCC patients, right? So we see these patients who have disease infiltration throughout their liver. They have some biliary obstruction from their tumor. They're not eating because they feel terrible, so their albumin's a little low. That's a very different phenotype from, as Rich said, these patients who, have massive ascites and encephalopathy before they ever have liver cancer. I think it's important to know that our patients really have two competing causes of mortality, right? They've got their underlying liver function and they've got their HCC. And so, when we see a patient beyond the Child-Pugh score, we really need to think about what's the biology of the tumor and what's the biology of the cirrhosis.
Yeah.
And it's two very different groups of patients who are both Child-Pugh B.
So with that, Dr. White will come discuss for us intermediate liver cancer, which is probably the majority of patients that present, I think, to the clinic, and how we best manage them.
All right, well, thank you for the opportunity to speak. I know interventional radiologists are a rare breed in this meeting, so I might be the only one in this building, I think. So if I run away, it's because I'm scared of you all. So we're going to do a brief survey and talk about a patient here. So based on the most recent clinical data, guidelines, and recommendations, how would you treat a patient with multinodular HCC, preserved liver function without evidence of extrahepatic disease? Do you refer them to me for an intra-arterial therapy? Do we think about ablation? Multinodular, so could we do multiple ablations? Stereotactic SBRT therapy? Are we going straight to systemic therapy in this patient population? Or are we going to do a combination therapy, TACE plus systemic therapy? So what do we think? And just like Dr. Finn, you may see this question again. So we have no idea. Good. I love it. All right, so what we're going to talk about is the wastebasket of BCLC, right? So BCLC-B intermediate stage. I don't even know, I had to give a talk about this at our national meeting this year, and I just said, I don't even know what to say, and sat down, because it's such a wastebasket term. So if I just wanted to start by talking about what it looks like on imaging and how these patients present. So intermediate stage, you have to remember, is something that's outside of Milan criteria. So they have extended criteria. So this patient has a single encapsulated lesion hanging off of the left hepatic lobe there. It's 5.1, single lesion, right? So that is an intermediate. Now go to the middle patient. This is a guy that has well-defined nodules, preserved portal flow, but again, multifocal disease. That's the same patient, same category, right? Not maybe same treatment, but same category. And then we look at this diffuse infiltrative extensive bilobar liver involvement. Again, these are all intermediate stage HCCs. And the BCLC guidelines would say we treat them all differently, but they're still in the same category, and we're looking at survival and those types of things. They're all in the same category. So this is a patient of mine, 75-year-old guy. He actually looked like Santa Claus, very sweet little guy, had MASH, cirrhosis. And he presented to the clinic after an MRI revealed a liver lesion. He actually had fallen down and hurt his back, and incidentally, here we go. He's got a single lesion. It was 6 centimeters at presentation. It was a LIRADS 5 lesion. And maybe he had a secondary lesion, but it was a LIRADS 4, and we'll see that on the next slide. His performance status was a 1. He's 75, right? Most 75-year-olds aren't going to be a 0, and his child's Pew was 5 at the time that I met him. So there's that second lesion. And so the primary management after multidisciplinary tumor board was, we thought, could we downstage this and maybe even transplant him? He wanted to get a transplant desperately, and so the multidisciplinary tumor board thought, could we do a radiation segmentectomy? So you can see that we did go on to do a radiation segmentectomy. We had a very nice response, and for a year we had a CR. But the patient then, a year later, developed recurrence along the inferior margin, and so this secondary site now turned into a LIRADS 5 lesion. So that site I showed you before was LIRADS 5, and so we decided to, multidisciplinary tumor board decided that we should switch to atezo-bev, for which he underwent 10 cycles. And then 9 months later, he had progression again. At progression, they asked me if I could clean it up a little bit with some TACE. So we went on and did a TACE there. There you can see some other sites of disease. But again, that radiation segmentectomy site had no other sites of disease. And again, what happens at the inferior margin? Again, worsening disease. He's got multifocal LIRADS 3 lesions and some 4 lesions. Again, they asked us to clean up a little bit more with TACE, and then he got switched to lenvatinib. Okay, so you'll see the theme here is that we're not going to do one thing. These patients are getting multimodality therapy as we go. A year later, then he progressed again. We started him on Ipi-Nivo, as we talked about earlier. He got 4 cycles of that. Then he went on to maintenance, and then he progressed. And you can see just what goes on. He goes on to now 4th-line therapy. And patient actually caught overwhelming C. diff infection, led to multi-system organ failure, and he actually died 2 years after initial liver-directed therapy. And so multimodality therapy is what this patient ended up getting, but initially he had a year of pretty good survival. So when we look at the BCLC staging system, you can see we're really focusing on that intermediate stage, and I showed you imaging examples of what those patients look like. But the therapies are very different, even though they're all categorized into one stage. You can see the very early stage, those patients were trying to either bridge to transplant, get them down into criteria. That middle patient that I showed you with those well-defined nodules, we're trying to get those patients some survival benefit and treatment response, and those patients are being directed to me, and then we have systemic treatment for those patients with a diffuse infiltrative that we talked about before. And so how do we do when we do downstaging? So do we do a pretty good job if that's our goal, is to downstage them to transplant if we fold in liver-directed therapy? So this was a study that looked at 950 patients, and what we found was that 50% of those patients were able to be downstaged. So how did we downstage them is really the question. Does it matter if you do chemoembolization? Does it matter if you do radioembolization? Or what therapy should you be asking your interventionalist to think about? And what it really showed was that multimodality therapy is the way we do it. It's never easy to downstage patients. If you have a single lesion in a single territory with an artery, fantastic. Radioembolization is great. But tumors never live in a single territory. They're always in a watershed area where there's a little bit of blood supply coming from this artery and a little bit of blood supply coming from that area. And so really multimodality therapy, as you can see, 60% of patients that were downstage successfully had multimodality therapy, and that's probably the right answer. But there was no difference in recurrence rates between patients that underwent chemoembolization or radioembolization. And so downstaging success, when we look at TACE versus TARE, which one should we do? Again, it probably, doesn't really matter. There's a horse apiece between the two. And these are just all of the studies that have looked at that in a retrospective manner. Again, these are old studies. The reason we're looking at old studies is because now, obviously, we have new regimens. So what about these well-defined nodules? In these patients, we're talking about palliation, right? We're not going to be curing these patients that have multifocal disease. And in these patients, TACE is the answer according to the BCLC. And we see that when the BCLC updated their guidelines, now our survivals are, it used to be intermediate stage patients had 11-month survival, and now we're seeing 2.5 years or greater survival. And so what kind of therapy should we be looking at? Should we be doing TACE? Which kind of TACE does it really matter? And the answer in these older studies was that maybe it doesn't really matter which liver-directed therapy as long as we're doing it. And you can see median overall survivals here are 37 months. And this other study was 28 months. So we have longer survival. We're getting better at what we do when we infuse liver-directed therapy. This was a really interesting study that came out of Japan. It was called the President Study. It's a recent study that Dr. Arai ran. And they looked at drug-eluting bead versus TACE. And so it was always the age-old question, do we put beads in there, or do we put chemoemulsion, or does it matter, or which one does the interventionalist do? And what Dr. Arai's study showed was that really you should be doing chemoembolization, and the theory is that you have a liquid, and that liquid is able to penetrate deep into the tissue of the tumor and kill that tumor with sustained response. And that's what he proved in this study. So a CR at 3 months. That was the primary endpoint, and you can see a drastic improvement in CR rates in patients that underwent the chemoemulsion. So we think probably that is the best way to do it if in fact that's what you want to do. What about Y90? Y90 is sort of, we all call it the new kid on the block. We've been doing this since 2003, although now we're labeled as of the last couple of years. And so what we used to do with Y90 is we park our catheter in the right hepatic lobe and hope, right? Are those microspheres going to go where we want them to go to the tumor? They go to the tumor because the tumors are hypervascular. But are we in fact doing good by those patients by just parking our catheter and hoping they go there? Or should we really be very effectively dosing them and doing dosimetry, as all the radiation oncologists have done? And what we found is that if we do personalized dosimetry, so we're really smart about it, we're smart about where we put the catheter, we're smart about where we put the beads, what we found is that there is a significant overall survival benefit when we use personalized dosimetry. So no longer are you going to come to any IR suite where we're just parking the catheter and hoping. We're going to do really good dosimetry to make sure that that dose is appropriate for the tumor that we're treating. And this is called the Dososphere study, where they looked at that. The premier study was run here in Chicago by Dr. Salem, and what his question is should we be doing Y90 or should we be doing TACE in these patients? These were BCLC-As he included, or Bs, and he had to stop this study because patients really just wouldn't enroll in it. But what he found was that there wasn't a survival benefit. So when we're looking at all liver-directed therapies, that's the bottom line, is usually we have yet to show a survival benefit. But when we looked at time to progression is significantly longer in patients that have undergone Y90. And so for a lot of these patients, that early stage in the intermediate group, our goal is to get them to transplant. Well, we need them to have a long interval with progression-free survival to keep them on that list. And so that's really dramatically changed how we treat those patients. And most of those patients, we're going to try to really do a Y90 because we know the PFS is so much longer, greater than 26 months in the premier study versus 6.8 when you look at the TACE group. And again, survival didn't matter in this patient population. So the TRACE study looked at chemoembolization using drug-eluting beads versus radioembolization for these patients. And what you can see is, again, prospective randomized trial, is you can see that the TARE patients did overall better when you look at their TTP. So their TTP, right, time to progression with the radioembolization, again, was 17 months versus 9 months. So again, it depends on what your goal for your patient is, but if you need them to have a long interval of progression-free survival for any reason, getting them to transplant, that it makes a lot of difference which modality you're using. And so what about these diffuse infiltrative patients? Those are those patients going on to systemic therapies. What is the best answer for them? And systemic therapy is what the guidelines say, but is there a role for chemoembolization in this group? Can we debulk? Can we make the tumor burden smaller? Can we sensitize the tumor? And so systemic therapy may be preferred in patients that are TACE unsuitable in intermediate stage. And so this study looked at lenvatinib versus TACE, and you can see those lenvatinib patients and those patients that maybe were unsuitable for TACE had a median overall survival benefit 37 months versus 21 months, which was statistically significant, as you can see here. What about the PFS? Again, when you combine therapy, so lenvatinib plus TACE in first-line therapy, so this was the launch trial, what happens when we combine those two? And you can see that if you do lenvatinib alone, your median overall survival is 11 months, but if you combine it with TACE, so put them together, which makes sort of sense, right? We're doing something at liver-directed therapy, and then following it with a systemic therapy, that our median overall survival was improved in this group, right? And our PFS was also improved in this group. So there is some data saying that, yeah, we should maybe think about this combination therapy. Maybe there is something to it. So what does unsuitable for TACE mean? How do we define that? And so when we look at patients that have single nodule or less than 3 nodules and they're less than 3 centimeters, we know that we're very, very good either at doing radiofrequency ablation, between 2 and 3, we like to TACE ablate, so do a little intraarterial therapy plus ablate. But what about the patients that are good for TACE? Those are those patients that have multiple nodules, but maybe like 4 to 6, but they're not huge. They're maybe 3 to 6 centimeters in size. Those are the patients that tend to have a good response with TACE. And then when we have these huge tumors, greater than 6 centimeters, and there's lots of them, which is that example I gave you before, those patients tend to have a poor response to TACE. And maybe those are the patients that we should be thinking about either combination therapy or systemic therapy. And so what we do know is that, and I'm preaching to the choir here, you all know this, that multidisciplinary care is really critical for patient outcomes. And so we know that single-day multidisciplinary conference improved survival in study number 1, study number 2, study number 3, study number 4, and study number 5. So the bottom line is you need to have a multidisciplinary approach to these patients. Though liver-directed therapy is wonderful and I do it every day, there's patients that don't benefit from it and or other therapies are better, and we need to have those folks at the table, transplant, hepatology, we all know who needs to be there. And so just remember that multidisciplinary care is really important in the care of these patients, because as we just talked about, a hepatologist's perspective on what this BCLC7 patient should in fact get, and are they really a BCLC7 or can we really push them, is critical to get their input sometimes. So Emerald 1, this was one of the easiest trials I ever enrolled patients in, because at the time we were not allowed to, or we weren't able to do combination therapy because of insurance constraints in the state of Wisconsin. And so this was a global double-blind placebo-controlled trial, and it looked at, just like some of the other trials that we've already heard about, where we did Durva plus Bev plus TACE. So we did Durva and then plus TACE, and then added the Bev on after, because Bev, what it does is it causes the blood vessels in the liver to get smaller, and so we can't deliver the drug effectively. When we do TACE, we typically have to stop the Bev for at least a month, versus TACE versus single therapy with Durva. And the primary endpoint was PFS in arm B. And anyway, we compared all these groups, and the secondary endpoints were PFS in the other groups. So the patients that were included were those patients that were not amenable to curative therapy, so these were not ablation candidates or transplant candidates. They were A's, but they went up to B7, right? So I just talked about those B7s. Without evidence of extrahepatic disease, and those VP3s and VP4s, that macrovascular invasion, were excluded. In your performance status, you had to be a 1 or less than a 1, right? So you had to have a good performance status, and they enrolled 616 patients in the study. And you can see the patient demographics. It's split very evenly, very nicely done. No real differences in the demographics of the patients in all 3 of the cohorts that were evaluated. And really striking data, I think, to us is that the patients that got the Durva-Bev plus TACE had improvement in their PFS at both 12 and 18 months. And it was statistically significant. So really made us think, should we be adding systemic therapy to those intermediate stage patients? Or for those patients on systemic therapy, should we be adding liver-directed therapy? The question remains, is TACE the right answer, or should we be doing other liver-directed therapy? And that question, I think, remains. But here you can see when we looked at just the single agent plus TACE plus placebo, there wasn't a difference. So you really need the triple regimen. Adding that Bevan did make a difference in their PFS. And so again, subgroup analysis, we can look at all of the different factors and which one really mattered. Tumor burden at baseline tended to matter when we added, it favored having those two drugs plus the TACE. But again, we can do lots of post-hoc analysis and look at these things. The time to progression was improved by 12 months when you added it. So again, we sort of saw that on the first slide. But TTP, which is really important to all of us, is improved when we have that combination therapy with chemoembolization. And then response and safety. Safety is really important, and you can see that the safety in all three groups were similar. What that tells me is that probably TACE is a thing that causes problems, but I joke. But certainly AEs are prevalent in all of the groups, but nothing, no huge significant difference other than the Durva-Bev, as you can see, probably had some study-related adverse events. And so I will ask you the question again, based on the most recent clinical data guidelines and recommendations, how would you treat patients with multinodular HCC with preserved liver function without evidence of extrahepatic spread? Intraarterial therapy alone, ablation, SBRT, systemic therapy, TACE, and systemic therapy. Let me see if I can get this. Oh, there we go. There we go. Yay. That's why you're all here, right? Medical oncologists, we're all gonna combine therapies. Okay. So rationale, Emerald 1, right? I just showed you the Emerald 1 data, which was an amazing trial to enroll in because everyone wanted to be on it because we couldn't give combination therapy. Is it part of current guidelines? Not yet, but I think we're all sort of moving there because with those patients with preserved liver function without extrahepatic disease, we've shown a survival or PFS benefit, so I think that makes sense. So what's coming? What do we have to look forward to? And you all are going to be the first to hear about many of these trials because this is where they all get reported out. Plus lenvatinib and TACE, Emerald 3, versus TACE alone in local regional HCC. That's a multi-center randomized open label trial, phase 3 trial. Primary endpoint is PFS and secondary endpoint is OS. So I think super interesting trial that will be combining all the therapies that we know and love. What about atezo-bev versus TACE in intermediate stage HCC? That's the ABC HCC trial. And again, primary endpoint is TTF and secondary endpoint is overall survival. So I think, again, another super interesting trial that we will be very eager to see what the response of that is. Here's another one, lenvatinib plus pembro plus TACE in patients with incurable and non-metastatic HCC, the LEAP-012 trial, multi-center randomized double-blind active control phase 3 trial, primary endpoint PFS and secondary endpoint PFS per RECIST. And they're looking at DCR and all those other things that are appropriate. So again, very interesting trials coming down the pipeline, regorafenib plus pembro versus TACE or TARE, which I think is very interesting because I think overall survival has not been shown to be different with either the therapies, even though PFS is different. So this is the REPLACE trial, and looking at those patients that have beyond that 7, so beyond the 7 nodules, bigger in size. So again, another interesting study that we will be looking to see the results of soon. So with that, we will turn it over to the panel. I don't know if Rich, you want to take back over? All right.
Yeah.
All right. Thank you very much.
Thank you very much. Very good. So also we have a bunch of questions that have come in, and maybe we'll start with the questions. So we'll start with a more general question. So for patients who are getting systemic treatment, IO-VEGF or IO-IO, TKI, how do you assess response as a radiologist? Are you using RECIST, modified RECIST, which looks like enhancement versus just the size of the tumor? And that relates to, TACE and Y90 as well.
I mean, we had to change all of our staging systems. I mean, our response systems, right, when TACE came game in Y90 as well. Y90, sometimes the tumors will look a little bit bigger. They will have less enhancement. So enhancement is really critical. Size is not necessarily as important, especially in ablation, right? Ablation, you get a bigger thing. And if a radiologist doesn't know that they've had an ablation, they'll say, oh, progressive disease and huge growth. And you're like, no, I did an ablation. But so we have to look at enhancement. Size is secondary. And then when we measure size, we're measuring residual disease. The other thing to be really watching for is when we do liver-directed therapy, the 1-month scan, especially after Y90, really, we've done studies and it doesn't show us much. We can't really see what the response is. We have to wait till 3 months. If you have an 80% reduction in AFP, then we sort of know we've done a good job, and maybe we won't get imaging at that 1-month time point. Some of us get imaging at 1-month time point if we're treating bilobar disease, because we want to see what's happening on the other side of the liver, the side of the liver or the sites of liver we haven't treated. But really, you're looking at enhancement of tumors to look at response.
So, it relates to also the discussion. I mean, Mark, do you use any objective readout for systemic treatment or TACE, TARE for these Barcelona Bs? I mean, is it just, I know it when I see it? Do you use up to 7? So for those of you who don't know, up to 7 criteria is the size of the largest lesion plus the number of lesions. So 1 lesion of 8 centimeters is beyond up to 7. 3 tumors measuring 3 centimeters. I say 4 lesions, they're all 3 centimeters, that's 4 plus 3, it's 7. Do you use any objective measurement for that?
We don't use any formal cutoff. I think it's important to think a little bit about biology again. I sound a little bit like a broken record, but there have been, again, retrospective analyses of systemic therapy versus TACE in intermediate stage. And what's clear is that unlike systemic therapy, local regional therapy does cause a detriment to the underlying liver function. And in an era now where we have not 1, but 2, but 3, effective lines of systemic therapy, it's really a shame when patients get so much local regional therapy that they miss an opportunity for systemic therapy. So, for me, there's no size explicit cutoff, but for me, I really think about how much normal liver will be impacted by the TACE, and that's a major swaying thing for me. So if it's a lesion that's way off to the side, that we can target with minimal damage to the underlying liver, I'm much more enthusiastic about local regional therapy.
So I just want to remind everybody, don't forget to fill out the paper surveys on your desk, just in case I don't want you to rush out of here. There's still more to come, and also that the slides are downloadable if you need them. So TACE or TARE? What is Wisconsin doing? Are there still patients getting TACE versus TARE? How do you decide?
So watershed tumors tend to be really challenging. And
you translate that for me. Watershed.
So yeah, watershed is the tumor that's sitting between. So typically, a beautiful tumor that we can do a beautiful radiation segmentectomy on is sitting in the middle of a segment where one blood vessel comes and there's an area, there's a margin around it. So I can go into one artery that's going to segment 8, and it's only being supplied by segment 8, and I can blast that away. I can take segment 8 out with a radiation segmentectomy, which would be equivalent to surgical resection. Now, if it's sitting in 5-8, right, it's sitting in the middle, and so there's 8 coming in up top, and there's 5 coming in on the bottom, or maybe there's a little, something else, then that's a watershed tumor. So it's in those areas of the liver where you're not getting only segment 8 blood supply, you're getting segment 5 blood supply. And so those tumors, I can blast away 8, but I still have 5 on the bottom that's giving, that has blood supply. Or if it's sitting off to the side, so I don't have a good margin around it, then we know that we're probably not going to get a great response with Y90. So will I treat, segment 8 with a radiation segmentectomy and clean up the bottom with TACE on the bottom? Surely I will. If there's a patient that has a high hepatopulmonary shunt fraction, so some of the beads are going around, usually those patients have, portal vein invasion, then those patients are getting TACE, and we usually do a TACE to reduce the shunt, and then we'll go on to do sort of what we talked about, this consolidative Y90. So certainly those patients that have tumors in areas that are not amenable to doing Y90 are those that are getting chemoembolization in our group.
So as we look at implementing Emerald once the regimen is approved, Dr. White first, is that a patient who everybody will get that? Is it going to be with TACE or TARE? How will you decide who gets that? Is it only for liver transplant patients, or how will you manage IO with transplant? What are your thoughts? I mean, you participate in the trial, you said, so.
So our transplant surgeons do not believe that immunotherapy is a contraindication to transplant. So they tell us every time we get on the call, it's not a contraindication. It's not a contraindication to transplant. So I think it's, as we talked about, those people in that little chart, that's the red category. That's another patient example. I think those patients in that red category are going to be those patients that we're going to siphon off and say these patients need to be in the Emerald 1 category and get both therapies.
Mark, what's your thought on Emerald 1, and is it going to be all intermediates? What's your thought?
Yeah, look, I'm a little more of a skeptic. I want to wait to see the overall survival data. I don't know, without looking at overall survival, I mean, we've made the scans prettier, there's no question. Have we really changed biology here, or are we just sort of trading a later benefit for an earlier benefit? And without overall survival data, and especially the way that the safety has been presented, where we don't really have the full denominator, I don't know. I think there are a lot of unanswered questions still about Emerald. And at the end of the day, this was a study of systemic therapy added to TACE. I think it's going to be really informative to see systemic therapy versus TACE. Again, I don't want to offend my fantastic IR colleagues sitting on the stage, but remember that the data for TACE and HCC in general is still a little bit controversial, right? I mean, there's a Cochrane review from 2011 that says TACE alone doesn't prolong survival, and yet we've just continued to add to TACE. And so I think more data from Emerald 1, but also data about, in a contemporary era, systemic therapy versus TACE may completely redefine how we think about intermediate stage disease. I clearly think there's a role for local regional therapy, but I do wonder if we're going to move towards a paradigm where it plays more and more of a role for oligoprogression, critical tumors, critical areas of tumor. So this may all evolve in the future.
And I'll just say you're welcome for the last 40 years while we took care of it while you figured this out. You're welcome.
So the REPLACE study is looking at Rego-Pembro versus TACE or TARE for higher risk patients, right? Those beyond up to 7. And I'll close with one question. There's a question from someone about radiation therapy, right? That it's not in the guidelines. And the reason right now it's not in BCLC and other guidelines is, and when I say radiation, I mean SBRT, external beam, is just the level of evidence has not really percolated up with large randomized studies showing that it's superior to what we have. Now, some institutions are very radiation heavy, and personally, I suspect SBRT is probably pretty effective for small tumors, but I think until they have higher level of evidence, well done, randomized data, it probably won't make it into the guidelines.
So I'm going to push back a little bit.
Well, no one asked you to, but go ahead.
We have large randomized phase 3 trials now of proton versus microwave ablation, where it's non-inferior and trending towards superior. We have randomized data of multiple studies of radiation, right, that are positive. I think it's not on the guidelines because there were no radiation oncologists at the table for the guidelines, right?
Well, that's another discussion.
I think it's important to understand that, depends who's at the table.
But I also think it's probably some institutional preference as well,
sure.
Regardless of the guidelines. But I don't think it's been shown at least superiority towards local regional treatments. Okay, so Mark, since you're so anxious to talk, here you go.
It's the danger of going third is they'll skewer me now. See. All right, so we've talked about systemic therapy in the advanced setting. We've talked about systemic therapy in the intermediate setting. And now I have the fun of talking about systemic therapy even earlier. So let's start with the pre-survey question. Which of the following is not a feature that is associated with increased risk of HCC recurrence following resection or ablation? And look at that. You didn't listen to me. So 68% of you got this right. All the other features here, and I'll scroll down, are risk factors for recurrence of HCC after resection. Etiology is not a established factor predicting recurrence, so very nice. All right, so let's talk about high-risk early-stage HCC, and we're going to talk about emerging checkpoint inhibitor therapy in this space. So these are the guidelines, and we're going to shift. Again, we've gone from right to left tonight, so we're going to talk about the early stage. And at least right now, the standard of care is resect and do nothing else, right? And there's really no other tumor type that I can think of. Again, I only treat HCC, so I may be wrong about this, but where we have highly effective systemic therapy that's really not used to cure patients, and at least a standard of care. So this may all be evolving soon. So this is some data about HCC recurrence, and recurrence is incredibly common with HCC after surgery. About 70 to 80% of patients recur after surgery. And there is this bimodal recurrence, so there's an initial peak early, and then the risk goes down, and then it actually goes up again. Although, remember that these patients have underlying cirrhosis, and they're at risk for de novo HCCs in addition to recurrence. And there's some question about how much of this later peak is actually mediated by totally new de novo HCC rather than true recurrence. We've certainly, as a group, thought about preventing recurrence. There's a strong need for adjuvant systemic therapy to prevent tumors from recurring. And about a decade ago, there was this trial, the STORM trial, that looked at sorafenib, which at the time was the only effective systemic therapy. I don't know if effective is the right word, but the only effective therapy approved at the time. And there really was no benefit to adjuvant sorafenib in the overall population as well as in any subgroup. And so, again, that's why up until this time, we've really had nothing to talk about in the adjuvant setting. The standard of care has been surgery alone, and after that, active surveillance. But fast forward to really just last year, there were the results of the IMbrave 50 study, and this is, as you'll soon see, the first positive randomized large phase 3 study of adjuvant therapy in HCC. So patients were randomized to active surveillance versus atezo-bev. And they continued atezo-bev for a year, and then the primary endpoint was relapse-free survival. This was not everyone. This was a group of patients who were at increased risk for recurrence. So eligibility included multifocal disease, patients with large tumors, or poorly differentiated tumors, or microvascular invasion. I have here also the eligibility, so patients could have resection or ablation, although almost everybody in the study had resection, so you can probably ignore the ablation category because that was a minority of patients on the study. Interestingly, there was no AFP as a high-risk feature. I know many of us are aware that AFP is a risk factor for recurrence. That was not included in eligibility. In terms of baseline characteristics, I want to credit them. They got a group that was pretty similar to what I think many of us see when we think about who gets resected. This was a global study. The majority of patients were in Asia. The majority of patients were hepatitis B associated HCC. And remember that the patients who we tend to catch with early stage HCC, the majority of them are in active surveillance, and that population is skewed heavily towards the hep B patients. And so, this I think is a very fair group to look at this in. And again, who enrolled? I mentioned this earlier, but the vast majority, almost 90% of patients were resection patients on this study. Ablation was a minority of the patients. And you can see the high-risk criteria here. One of the questions that comes up is this reflective of who has surgery in a Western US population? And I'll just point out that only about 15% of patients were not what we consider by contemporary Western guidelines to be resectable. So the vast majority, 85% of patients in the resection group were Barcelona stage A. And you may have seen this data, but this is a positive study in that it hit the primary endpoint. Relapse-free survival was improved. The hazard ratio was 0.72. And these are the curves here. This is pretty early data, so we should see follow-ups to this data. I think obviously it's exciting to have a study that hit its primary endpoint, but we continue to ask some of the same questions we asked with the EMERALD-1 data. Have we truly cured patients? Have we truly changed the trajectory of the disease, or have we traded a later benefit versus an early benefit? We don't yet have long-term overall survival data, so I think it's hard to answer that question. But clearly there's some separation of the curves, and this is clearly a positive study. This is not yet FDA approved. In terms of safety, I think the safety of this regimen in the adjuvant setting is exactly what you would expect. Again, we have a lot of experience with this in the metastatic setting. So you can see here that the side effects were expected. There were some bleeds, and again, patients did undergo EGDs. The rate of bleeding was low, but non-zero, and there were fatal bleeding events in the atezo-bev arm. And I think this is something to always think about when you talk to patients. In the advanced setting, they have HCC, they're going to die of their HCC. It's a different conversation when someone may be cured by surgery alone. Are you willing to accept a small but non-zero risk of bleeding? I'll just mention very quickly, there was no monotherapy arm with the atezo-bev study. It was atezo-bev versus placebo. There is a smaller randomized phase 2 study from Asia that looked at a PD-1 agent alone versus placebo. This was recently published in Nature Medicine, and this is also a positive study, but this is a much smaller study. So I think the jury is not completely out about whether we need the BEV or whether PD-1 alone would bring the benefit, and that should be answered in the near future. I want to shift gears very quickly to something that's near and dear to my heart, which is neoadjuvant immunotherapy. There's some, at least theoretical advantages to giving immunotherapy before surgery instead of after surgery, and the theoretical benefit is that the tumor itself can act as a sort of in situ vaccine. So immune cells come in, they get educated, they leave the tumor, and then they can reduce the micrometastatic disease while the patient is healing from surgery. And this has at least been shown in other tumor types. So this is data from melanoma where patients received pembrolizumab either before surgery and after surgery or only after surgery. And there was a clear benefit to the neoadjuvant versus the adjuvant-only group. I think this will be answered more definitively at this ASCO. I'm told that there's a study of neoadjuvant Nivo-IPI that's a much larger study in melanoma, so we should actually get more data about this. Where are we with HCC? We're really stuck looking at a couple of small institutional phase 2 studies. There was a study of Nivo-IPI versus nivolumab alone at MD Anderson, where this was found to at least be safe and feasible with a pathologic response rate of about 20%. There's also a study of PD-1 alone from the MD Anderson, from the Mount Sinai group, very similarly found that this was reasonably safe, feasible, and had some pathologic responses. And then we had also a small series looking at a TKI plus nivolumab. This study was a little bit different. These were patients who, at least initially, were deemed to be unresectable, and largely because of biology. So these were patients with very large tumors where the risk of recurrence was very high or macrovascular invasion. What we showed is that it was at least reasonable to give neoadjuvant immunotherapy and then resect them. And many of these patients who normally would not be considered for resection appeared to be cured or at least have very long survival after surgery. How about before liver transplant? I think this is a question that comes up a lot, especially now when it's not that unusual that we get patients who you would never think about liver transplant. When you meet them, you put them on systemic therapy, and then suddenly things start to shrink, and next thing you know, they're within Milan. So how do we feel about transplanting patients after immunotherapy? We don't have any prospective evidence yet, but this is retrospective data that was collected that looked at patients who got immunotherapy and then had transplant, and what you can see is that overall, these patients seem to do okay. The rate of rejection was not vastly higher than you would expect to see from a population that did not receive neoadjuvant immunotherapy. I have to say, looking at this, I'm a little surprised. Some of these patients got a dose of nivolumab a day before transplant. I don't quite know how that happens. I don't know if that happens at your centers. A little bit strange, but somehow these patients did okay. So at least right now, guidelines say that if you give immunotherapy before transplant, that is probably okay. At our institution, we like to wait at least about 3 months from the last dose of immunotherapy before transplant based on available evidence. The converse does not appear to be true. So immunotherapy after transplant should be avoided. There's about a 36% chance, at least retrospectively, of liver allograft rejection. So the chance of rejection seems to be perhaps higher than the rate of response to these agents. So in general, we really do try to avoid immunotherapy after transplant. So let's talk about perioperative strategies. So if you have a patient who's unresectable and you want to downstage them to surgery, how do we do that? Well, we saw some beautiful data about local regional approaches. And I think, at least today, these have numerically the highest chance of downstaging. And I think there is the right patient where local therapies are the way to go with resection patients or patients who are outside resection where you need to downstage them. But neoadjuvant immunotherapy does have a response rate, probably in the 30% range from the Bev-Atezo data, but has the advantage of reducing micrometastasis. So I think giving a systemic therapy perioperatively is different than giving a local regional therapy. And then we do have now real phase 3 positive data for adjuvant Atezo-Bev with other adjuvant studies on the way that we'll talk about in a moment. So where are we with our guidelines? These were just updated. So the NCCN was just updated really just last month, and basically for the first time offers the potential for Atezo-Bev in the right patient on a case-by-case basis. And maybe I'll just ask, Rich, is this something you're using yet?
I have. We don't do a huge number of resections in the West, literally the Western world and Western United States. But for those who have met this criteria, I have offered it. I've a handful of patients, 3 or 4 patients who are various phases through their year of therapy.
All right. So let's talk about lessons learned. So I think that the real data to talk about here. Did I lose my microphone?
I'm
back.
back.
I'm back. So the big news here is Atezo-Bev adjuvantly is associated with improved recurrence-free survival in HCC. This is a positive study. I think many of us anticipate this may become FDA approved. Is this truly practice-changing? We don't have long-term overall survival data. The curves, at least so far, very early days, but they come together, which is not really what you want to see with an adjuvant study. You love to see them separate more and more over time. But 30% reduction in recurrence-free survival is meaningful, I think. And I agree with Rich. It's something I'm offering on a case-by-case basis, particularly for these patients who are very high risk. Vascular invasions found after surgery, patients whose AFP doesn't normalize, patients who are ctDNA positive. It's something that I've started to integrate into my practice. What can I say about neoadjuvant immunotherapy? I would just say this remains investigational. It seems feasible. It's not something that should be done routinely off of a clinical trial, I think. But I do think that if you have patients who are unresectable, start systemic therapy, and then are downstaged, it is completely reasonable to consider them for curative therapies. And I think there is sufficient data to say that those patients do very well with surgery. Do they need surgery? This comes up. I've had patients who have amazing responses to immunotherapy, get downstage, go to surgery, and then there's a complete pathologic response at surgery. And so surgery becomes almost like an adjuvant therapy. Did they really need the surgery? We don't really have an answer to that question. But very exciting time, and clearly immunotherapy has moved earlier in the treatment paradigm. So let's talk about ongoing studies. So this is an eagerly awaited study, the EMERALD-2 study. I mentioned the study that is available is Atezo-Bev versus placebo. So one of the questions that invariably comes up is, would Atezo alone have been enough? And we will get a definite answer to that with the EMERALD-2 study, because that has a durvalumab monotherapy arm, so we'll get to really know the contribution of components. Again, very similar population, powered for relapse-free survival. And then we also have studies of PD-1 alone, a study of adjuvant pembro versus placebo. This is the Keynote 937 study. We know that this did not stop early. It's going to the final analysis that's been publicly announced, and so it raises questions about maybe we do need the Bev, but we will see. And then this is a study of adjuvant nivolumab versus placebo. Again, very similar study, phase 3 study. So we will know for sure whether PD-1 alone is enough or not. But again, I think it's just so exciting that immunotherapy has moved up, and at least so far, we're 1 for 1 for positive adjuvant studies. So it's exciting. So most of you got this right before, so please don't change your answer if you got it right before. Otherwise, I don't think I get paid tonight. No, I'm just kidding. Which of the following is not a feature that is associated with increased recurrence following resection or ablation? Well, this looks promising. All right. 95%. We can't do better than that. 5% people just click the wrong button, guys. This is great. This is fantastic. So let me ask you, Rich, etiology, does it matter at all?
Not in treatment decisions alone. There was a study that suggested that non-viral or NASH/MASH associated liver disease did not respond as well to IO. That was mostly a lab-based study. But when we look at the prospective data, that has not really materialized. So when we go to considering patients for treatment, etiology alone does not come into play.
And there appears to be an error with this slide. You guys got it right. Etiology is not a risk factor for recurrence. AFP is a risk factor for recurrence. Interestingly, though, it was not a factor that was used to enroll patients in the IMBRAVE 50 study, so that may be where this confusion came from. All right.
Okay. So I'll take it up.
You want to moderate the last
as
session?
we have a few more minutes. Again, don't forget to fill out the paper surveys, and you can download the slides. When we talk about sequencing, right? I mean, so say patients are going to get atezo-bev for an adjuvant indication or durva-bev with TACE, and then they progress, or at some point they progress. How will that weigh on your treatment when they develop metastatic disease? Mark?
Well, there's clearly data that anti-VEGF therapy is beneficial post-progression on anti-VEGF therapy, right? So cabo, regorafenib, ramucirumab all have benefit post-sorafenib, and I think we can extrapolate that in a post-bev setting. I think the principle is VEGF remains useful. I also think, and we'll have more information on Tuesday when the Checkmate 90W study is presented, but I think there are patients who respond to CTLA-4 who are different from patients who respond to PD-1. So I feel very strongly that there's a role for CTLA-4 in the post-bev PD-L1 setting.
Yes, and these studies aren't designed to answer that question, but the idea that IO might behave differently than IO-VEGF or IO-TKI. And that might relate into how we sequence drugs in the future. Right now we'll sequence, as I mentioned, from IO generally to TKI-based regimens. What about IO beyond progression, right? Patients are progressing with atezo-bev or durva-tremi. Do you automatically switch, or will you look at an oligometastatic, one lesion growing? I think, Dr. White, you commented that you'll ablate something and then continue. I mean, I don't know that we have evidence for that, but I think I tend to do that sometimes too. A small growth, continue a local treatment.
I'm a big believer in this. And the thing I want to just comment, Dr. White presented this case of sort of oligoprogression, recurrence at the margin. Each time that she intervened, the systemic therapy was also switched, which I really like. So sometimes we see these patients who just stay on atezo-bev forever with repeated local regional therapies, and these patients sometimes miss opportunities for systemic therapies that could help them. And so I actually really like the case that you presented, because it seemed like that patient, maybe not the best outcome with the C. diff, but got the best of what we have to offer today.
So, I want to make sure we get through these polling questions, and if we have time, I'll take another question. But for you guys in the audience, do you plan to make any changes in your clinical practice based on what you learned in today's program? Okay, I guess we don't see the results. Please take a moment to enter one key change that you plan to make in your clinical practice based on today's education. I guess that's a fill-in. And so I'll finish up with some questions we have here as well. There was a question about the Wnt pathway, right, and how that might affect treatment choices. There's a question here about with sorafenib, but I think the more relevant question was, there's been data that suggests that maybe Wnt activation is a resistant mechanism to IO. There are several ongoing studies trying to look at that. Regarding choice of frontline therapy, there's a question about PD-L1 expression. Mark, comment?
Yeah, we really have no effective biomarker for HCC right now. PD-L1 does not predict benefit. TMB does not predict benefit. Wnt beta-catenin signaling mutations do not predict lack of benefit from PD-L1. They do predict greater benefit from sorafenib, although not enough that I would ever use it as a frontline regimen over one of the immunotherapy regimens. So, unfortunately, we don't have anything good.
And last question, how do you differentiate between atezo toxicity, or we can say any checkpoint inhibitor toxicity, given now that durva is also being combined with bevacizumab toxicity? How do we differentiate those toxicities? Well, they're very clean. Certainly bev toxicity we know is hypertension, proteinuria, potential bleeding, whereas atezo is very much immune-related adverse events. Sometimes we see patients' Child-Pugh score rise during treatment, and that becomes, a sense of whether this is treatment toxicity or is this tumor progression. So I think we always need to get imaging on those patients. Also, the pace at which these toxicities develop are important, because sometimes it's just progression of underlying liver disease as well. So if the tumor is controlled, I think we always need to keep in mind about cirrhosis, and depending on the degree of liver dysfunction, enzymes in the thousands or even the high hundreds, you need to worry about IO toxicity. But I think we are out of time. I'd like to thank my colleagues. I'd like to thank CCO and as well as AstraZeneca for their support. I'm getting one more question. So I've had 2 liver transplant patients who have received IO post-liver transplant for HCC recurrence and METs. The immunotherapy has kept them both alive for 3+ years so far, including one who had cardiac tamponade from tumor. In your practice, is immunotherapy always a contraindication of post-OLT? So I have used it, but usually it's late line, right? And also for patients who are years out from transplant. I mean, part of the concern is, you have patients on immunosuppression, so the brakes are on, then you're giving IO to turn on the accelerator of the immune system. It's a little counterintuitive. I did not see rejection, but I didn't see any activity. These are clearly outstanding responses, but I really need to stress you need to do this with extreme caution and in close collaboration with your hepatologist.